This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Stacey Clardy from the Salt Lake City VA and the University of Utah. Today, we're talking with Elia Sechi of the University of Sassari in Italy about his recent paper published in Neurology. The title is Risk of False Positive Acetylcholine Receptor Autoantibody Positivity by Radio-Immunoprecipitation Assay in Clinical Practice. Welcome, Elia. Thanks for joining us.
Oh, thank you very much, Stacey, for having me over today.
We're so glad to have you. You know, Elia, I was catching up on signing my clinic notes over this past weekend, and I thought a lot about your paper in terms of the importance of understanding the results of lab tests. You know, in my mind, I always think it should take me just a few minutes to polish up my clinic notes and my recommendations and quick review the labs. But invariably, I spend a really long time analyzing the results of any lab tests that I ordered when I saw a patient in clinic, sometimes just as long as I did with the entire clinic visit itself, because understanding the results of each lab test directs really the crucial next steps in the care of the patients and the evaluation, maybe any referrals. Sometimes it profoundly changes the direction of what I initially thought my plan would be. And so it's so important to look at assay performance characteristics. And that's what you've done in this paper, specifically for the acetylcholine receptor antibodies as it relates to evaluating a patient for myasthenia gravis. So you note in your paper that although the cell-based assay has maybe more recently been shown to be a very accurate test for the detection of acetylcholine receptor antibodies in myasthenia gravis, the radioimmunoprecipitation assay remains the gold standard because of its wide availability. And, you know, over time, we've all been taught that it has a really high specificity, somewhere in the range of 99%, which is fantastic for a lab test. But as you point out, data on a large real-life population is pretty scarce here. So, Elia, tell us about the population. What did you find in terms of how well the assay actually performed in the real world?
I think there is one clarification first to be made, because specificity, as you said, was actually not close to 99% also in our paper. The point is that specificity is a parameter which reflects the quality of the test itself. So how well the test is performed in a lab. It doesn't reflect the characteristics of the population tested, specifically the frequency of the target disease in the population, which is very different because it doesn't change based on the population. A more useful parameter for clinicians is usually the positive predictive value, which is a sort of a slightly different measure of accuracy of the test, which is directly affected by the frequency of the disease in the population. And we know myasthenia gravis is considered a rare disease with a low frequency, with a low prevalence in the population. So we ended up finding in our study that when large populations of patients are tested, the specificity may remain very high, around 99%, but the positive predictive value may decrease consistently. So this is the main finding, and I wanted to explain this difference first. So what we did was to test a large population of patients, approximately more than 4,000 patients who were tested for acetylcholine receptor antibodies in our lab at the University of Sassari over approximately 20 years. So a large cohort of patients, a real-life cohort of patients, a single-center cohort. The patients were tested by a radioimmunoprecipitation assay that, as you said, remains the gold standard, is the most used still in many labs in the world. And we used a tighter threshold for positivity of 0.5 nanomoles per liter or greater, which is the threshold that is used in most labs with this assay. And we found that during the study period, approximately 450 patients tested positive for AChR antibodies. And of these patients, we of course excluded those patients with clinical information unavailable. So we ended up including approximately 360 patients for the study. For these patients, we reviewed the medical records to determine whether the clinical phenotype, EMG findings were consistent with myasthenia gravis, or they were more likely to have an alternative diagnosis. So we labeled the patient as having a true positivity for AChR antibodies or a false positivity for the antibody.
The point you just made about the fact that the assay is good, but the population tested is always of relevance, because the positive predictive value is really what is meaningful to us in our practice, right? What are we looking at in terms of, the patient we're evaluating? Any test can be perfect, but if a perfect test, in theory, right, we know perfect test doesn't exist so much, but if you had a perfect test, but you applied it to a population where they are not likely to have the disease, it really loses its value. And so in your real world population, you're telling us, I think the math works out to almost 14% of those patients who did not have myasthenia gravis did have a positive result for the acetylcholine receptor assay. So what can you tell us about the alternative diagnoses you found in that real world population for those who did technically have a positive result, but did not have myasthenia gravis?
This was actually very interesting to investigate, because the spectrum of, let's say, alternative diagnosis in patients with false positive results was quite broad. And this ranged from neurodegenerative diseases, demyelinating CNS disorders, functional neurologic disorders. Some patients were not even aware to be tested at some point. And so it was very variable. I remember a couple of interesting patients that I can consider interesting mimic to mention. Let's say one patient I remember with diplopia, persistent diplopia, not fluctuating. He ended up having a Parkinson's disease. And we know diplopia is well described as a possible symptom in Parkinson's disease. And so this was the final diagnosis. Another guy, a younger guy, around 25-year-old, he was referred for new onset diplopia. And he already had a brain MRI scan, which was reported as negative. But after review, we found a tiny demyelinating lesion in the dorsal pons that, as you know very well, is very characteristic of MS. And then over the 2 years over the following 2 years, he accumulated new demyelinating lesions. And so his final diagnosis was MS. So very broad spectrum. Some patients had ophthalmologic diseases. Many patients had just non-specific fatigue in the context of systemic autoimmune diseases like lupus or just sclerodermia. It was very broad spectrum of alternative diagnosis. Very interesting also to review. The records of these patients was very educative also for us.
You make some great points with those cases, and that's certainly been my experience as well. Maybe some of it's referral bias, but often in my clinical practice, I'm seeing people who end up having something else, perhaps more of a systemic autoimmunity. And there's this sense that perhaps they are more likely to throw a low false positive titer for some of these conditions. But arguably, those are the patients where it's even more important that we figure out what exactly is going on and avoid unnecessary, say, empiric treatment for myasthenia gravis. Along those lines, did the titer on the assay help you sort out the likelihood that it might be a false positive patient? Meaning, were there low positives that were perhaps more likely to be the false positive? So if you had a lower titer, just barely above that cutoff, did that make you more likely to have another diagnosis?
Yeah, this was one of the major points in our study. What we did was to review the medical records. Initially, 2 investigators independently reviewed the records for each patient. They had to come up with an agreement in the end. If there was disagreement, I had to review the records. But these investigators were mostly blinded to the titer. But what we found was that false positive patients were more likely to have a low titer, generally between 0.5 and 1 nanomole per liter, while the true positives, they had a way greater titer, with a median of 5, 7. I don't remember clearly the numbers, but significantly higher. And this was a main difference. This is also perfectly in line with what we see with other antibodies, as you know very well. Let's think of MOG antibodies and GAD65 antibodies. We know there is a strong association with low titer and false positive results. So I think this makes a lot of sense.
Titer matters, clinical context matters. I always try to remind myself of those two things. Now, you went a step further in your analysis and you had some serum available for some of these patients you looked at retrospectively, and you retested available serum on 7 of those non-myasthenic patients, and you tested it by the cell binding assay, or the CBA, which is the newer assay, but that is not available everywhere in the world, but we think is perhaps a better assay. So what did you find when you compared the cell binding assay to the results of the radioimmunoassay? Can you explain those results to us?
We were actually able to retest some of the patients during a follow-up visits in the clinic with different assay, specifically the commercial fixed cell-based assay. We now know it's more specific, and we found that out of 7 patients, false positive patients that we retested, 6 of them were tested negative, and 1 of them tested positive for the fetal isoform only of the receptor, which still clinically remains of unclear significance. And also, this is very in line with what we see with other antibodies. Again, we know that CBAs, either fixed or live, if available, they perform way better than radioimmune precipitation assay or ELISA or all those assays that rely on denaturated proteins. So with these assays, you can find reactivities against intracellular epitopes that are physiologically not available for binding on the surface of the cell, or you can just have a transient antibody production as a consequence of antibody spread, of epitope spreading due to neuromuscular damage from other diseases like myopathies or ALS. We also know that antibodies can be produced in patients with thymoma without symptoms of MG, and we did not investigate this specifically because chest CT was not available for all patients, but we know this is a possibility from the literature. So we just found that patients with false antibody positivity, most of the time, a transient positivity. So if you retest the patients after a few months, you're very likely to have a negative result. And similarly, if you retest these patients with a different assay, the CBA specifically, you can confirm the false antibody positivity. So these are the main take-home messages.
You covered a lot in that answer, including how to determine if it's a false positive, but also not stopping there, right? You're getting at asking the deeper question, the harder question of why might a patient have a false positive? Does a patient have a thymoma? Does a patient have something else going on with their immune system that's causing them to throw this low false positive signal, right? This is so important. Step 1 is really saying, is this myasthenia gravis or not? And then step 2, going beyond that, and it is big to get through step 1, right? So we're not treating people inappropriately, but step 2 of getting to the, why might this have happened to this person now? And to your point, you say, one easy thing you can do is if it's a low false positive and it's not fitting clinically is just retest in a few months. It may be transient. Sometimes it will go away. Sometimes it stays a low false positive. And really then you have to dig a bit deeper. And this gets into uncomfortable territory, right, Elia? These are some of the patients who have immune syndromes that we don't always necessarily have a full picture of, but important, again, to recognize there's something else going on in those patients and not treat inappropriately. That was a very helpful answer to me. Now I want you to, if you can, actually just walk me through a referral to your clinic. So you have a referral, it's maybe a low or maybe even a moderate titer positive for the acetylcholine receptor, IgG, so the radioimmunoassay comes to your clinic. Appreciating that the lab tests are part of what you're looking at. Walk us through how you're handling the evaluation of that patient from start to finish. Tell me how you're approaching that patient when I send them to see you in clinic.
one of the most important things to clarify from my paper, that I don't want to be misleading at all, is that not all patients with a low titer positivity are false or are likely to be false, because a good proportion of true positive patients, they had a low titer positivity between 0.5 and 1 nanomoles per liter. So this may happen in patients with a very, very typical MG phenotype. These patients may have a low titer positivity for many reasons. They might have received immunotherapy before testing, or they just might have fluctuations in titer and they initially low titer. So this is not a general rule, and the take-home message is just that the clinical manifestations rules the investigations in clinical practice. This is always the main rule, because if you find a low titer AChR antibody positivity by radioimmune precipitation assay in clinical practice and the symptoms are totally consistent with myasthenia gravis, that is a true positive result. You don't need to do anything else, in my opinion. You trust the clinical phenotype. On the contrary, if you have a low titer positivity and you realize the patient was tested in a low probability situation, let's say only non-specific fatigue that you may have in a number of chronic autoimmune diseases, systemic autoimmune disorders, or just a very transient episode of diplopia, and the patient was tested by the general practitioner for AChR antibodies, but this is all, there's nothing else to suggest myasthenia gravis, then the pretest probability is quite low, and you should be skeptical and reconsider the diagnosis. So do not trust the test in any situation, but do not consider any low titer positivity a false positivity. This is very important, actually.
This is really what it always comes down to, isn't it? It is sort of the paradox we face as neurologists, right? Having enough confidence in our gestalt, in our clinical exam, in any other pieces of perhaps history or auxiliary data we have to help us put together the meaningfulness or not of any test results that we have. You make a great point, and that is so helpful. And Elia, I want to thank you again for taking the time to discuss this work and also how we need to frame this work, looking in detail about the performance of assays in the real world. The paper, again, is Risk of False Positive Acetylcholine Receptor Autoantibody Positivity by Radioimmunoprecipitation Assay in Clinical Practice. You can read all the details in the journal Neurology, online or in print, available now. Thank you so much, Elia.
Thank you very much.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.